this session. These are a few challenging cases that we would like to share with you. The clinical aspects would be covered by me and the pathological aspects would be covered by Dr. Kashyap. Progressive, there was restriction of extraocular movements. We did a CT scan and found a large infiltrative, poorly circumscribed mass which was involving the orbit and the maxillary sinus, and there was evidence of multiple foci of calcification. We suspected a malignancy based on the clinical and the imaging findings, and we did an incisional biopsy.
Now, the biopsy which we received in our lab, histopath examination of this specimen revealed a malignant round cell tumor. As you can see, this is the low power picture where you can see these dense blue cells, areas of hemorrhages, and this is the high power picture where you can see these small round cells with minimal cytoplasm. They have a lot of mitotic figures. So we resorted, all round cell tumors look the same. We have to resort to immunohistochemistry in order to confirm our diagnosis. So we did a panel of immunohistochemical stains like NSC Desmin to rule out rhabdomyosarcoma, MPO to rule out chloroma, and these were all negative. CD99, however, was positive. Here is the CD99 stain. This was positive in the tumor cells. But along with that, CD99, once it's positive, you can see that positivity in both E-wings as well as PNET. So to differentiate between the two, you have to do a PAR stain, which was negative in this particular case. So this was a primitive uroectodermal tumor or PNET. Orbital PNETs are very rare, and they have a lesser propensity for metastasis as compared to the other PNETs in other locations. However, long-term aggressiveness, we really don't know much. And imaging findings already, Dr. Bhavna has already discussed about the imaging findings.
Okay, so now we come to case 2. Case 2 was a 15-year-old female who presented with painful proptosis of the left eye since just 3 months. She had sudden loss of vision for last 15 days. On clinical examination, there was restriction of extraocular movements in all the quadrants. There was severe exposure keratopathy due to proptosis, conjunctival chemosis was there. Her systemic examination was within normal limits. On imaging, an MRI showed a left intraorbital mass. There was scalloping and erosion of the orbital roof. So on the basis of clinical and imaging, we were suspecting a round cell tumor.
Initially, this patient was referred to us for FNAC since it was a palpable mass, and on FNAC, this was a GIMSA stain. We saw these large round to oval cells with abundant cytoplasm and eccentric nucleus. So these are plasmacytoid cells. We did not get any further clue. There was no other differentiation in this particular tumor, so we could not provide any definitive diagnosis. So the surgeons went ahead with the excision biopsy, and this is the cut section of the mass. As you can see, it is a grey-white firm mass, and we got the histopathology, which was very surprising. We had this numerous giant cells, as you can see, multinucleate giant cells filled with many nuclei, and here you can see this pink material, which was the osteoid. And this was the fibrous stroma in between. Next slide. Here again you can see this pink material, which is diagnostic of this particular tumor, and this is the undecalcified bone calcification which was present at certain areas. And here on high power, again you can see these giant cells over here. But what was diagnostic about this lesion was the pink material, the osteoid, which gives away the diagnosis. And although there was very little pleomorphism, not many mitotic figures, but depending on this pink material, we gave a diagnosis of osteosarcoma, extraskeletal osteosarcoma of the orbit, which is again very rare in the orbit. It's uncommon. Usually they arise in the long bones. Aggressive, they're highly aggressive with a high metastatic potential, and as we all know, it's reported in infants which are radiated for retinoblastoma. Otherwise, they are very uncommon, and there's only one isolated case report in a 22-year-old male.
Okay, so case 3 was a 66-year-old male who presented to us with bilateral proptosis, right more than left. This was non-axial, painless and progressive for 3 years. The visual acuity was 1/60 in the right eye and 660 in the left eye, which was explained by mature senile cataract in both eyes. There was no cervical lymphadenopathy. Systemic examination was unremarkable. So a trucal biopsy had been done outside before the patient came to us. That was 2 years ago, and it was reported as an inflammatory pseudotumor. The patient had had a history of oral steroids for 1 year. He had shown a partial response, but then it relapsed again. Steroids were discontinued and the patient was referred to our center. So on imaging, you can see how both the orbits are occupied by intraorbital masses, both sides. And apart from the orbits, imaging in other areas showed retroperitoneal soft tissue masses as well. So we did a biopsy in this case.
Now, in this patient, as was told earlier, that this was diagnosed as an inflammatory pseudotumor. Now, you can understand why. Actually, there were some areas in this particular biopsy which showed these lymphoid aggregates, and the rest of the tumor showed these infiltrative, the fibrous tissue. In the background, there were these inflammatory cells, and this is a low power picture, so you cannot appreciate the macrophages, but in the high power, you can see there were a lot of histiocytes. All these are histiocytes in the background of inflammatory cells. Now, it's very difficult. You have to resort to immunohistochemistry to get to a particular diagnosis. Inflammatory pseudotumor as such cannot be diagnosed on this case. Now, we did resort to immunohistochemistry. The IHC stains CD68 was positive in this particular case, but CD1A and S100 were negative. So this was a non-Langerhans cell histiocytosis. Since CD1A and S100 is negative, it was already shown one Langerhans cell histiocytosis where you have CD1A and S100 negative. Since these two stains were negative in our particular case with only CD68 positive, with the radiological details also typical of this particular case, along with the histopathology, this was diagnosed as an Ardem-Chester disease, which is pretty rare, and this has been published in 2012.
Okay, so case 4 was a 45-year-old male who had pain in the right infraorbital region and proptosis for 1 year. He presented with a globular mass that was 2.5 into 4.5 centimeters, rising in the inferior fornix. It was firm to hard-on palpation. A CT scan was done which showed a large retrobulbar soft tissue mass with dense calcification. Bone was normal.
This particular case, the entire tumor could not be removed because of the vascularity. So whatever the mass was, this is the mass which was sent to us, a grey-white firm mass. And the histopathology showed two different types of cells. One was these undifferentiated cells, and the other was this cartilage which was present. So based on these two different types of cells, the cartilaginous cells and the undifferentiated malignant cells, this was diagnosed as a mesenchymal chondrosarcoma extraskeletal, which is again very rare in the orbit, which is highly malignant, extremely rare as I told you, and usually it affects young females, and it has a very poor prognosis. They metastasize to the lung. This again has been published in 2001 in Orbit.
So now we come to case 5. This was a 40-year-old female patient who presented with a proptosis of 1 year duration but rapid progression since 4 months. There was a large mass below the right eye. The eyeball had been pushed anteriorly and superiorly. On ultrasound, an ill-defined mass with high internal reflectivity was noted. A contrast-enhanced CT scan, as you can see in the picture here, showed extracorneal inframedial mass with cystic spaces and fat.
This is the mass that we got in the laboratory. As you can see, it has a glistening appearance. It's a huge mass, 6 by 3 centimeters, which was sent from the lower lid. And microscopy actually revealed there were both cellular, less cellular areas, paucicellular, as well as highly cellular areas. Now these are one of the paucicellular areas. They show a myxoid background in which there are these spindle to stellate cells were present, and there was a lot of vascularity. You can see these vascular channels, And on high power you can appreciate there were these typical lipoblasts which were present in the tumor, which gives away the diagnosis of a liposarcoma. Now we also had some cellular areas, and S100 stain was negative. So together with the lipoblasts and S100 positivity, this was a myxoid liposarcoma.
Coming to case 6 now. This was a 7-year-old girl who had history of a mass involving the right orbit. Surprisingly, it was noted at birth itself, but medical attention was sought very late. There was progressive increase in the size of the mass, and no eyeball was noted clinically. On CT scan, again, it showed a large mass with both solid and cystic components involving the right orbit. There was expansion of the bony orbit with significant bone remodeling, and as you can see very interestingly in this picture over here, an ectopic tooth was noted. There was no intracranial extension. A lid sparing excitation surgery was done in this case.
Now this is the mass that we received, the entire mass. Bhavna, next. Yeah, so this on histopathology showed all the elements of all the 3 germ layers. We had these squamous epithelial lined tissue with hair follicles. Then we had this colonic epithelium which was present. We also had this bone with marrow elements and the fat tissue. Here the cartilaginous elements, again the bone and the adipose tissue were present. So all the 3 elements of the germ layers was present in this particular case. So this was but there were no malignant cells. So this was a benign teratoma, which are again very rare tumors that are derived from the totipotent cells. They commonly found in the testes and the ovaries if they are derived from the germ cells. Or in the body midline if derived from the embryonal cells. This is in the orbit, it is a very rare entity. This is again published in Orbit.
So now we come to the last case of this session. This was an 11-year-old girl who had history of blunt trauma 4 months back. She developed swelling around the right orbit. Her visual acuity was 6/6. The extraocular movements were within normal limits. We did a CT scan which showed a mass involving the lateral right orbit. It was suggestive of dermoid on imaging, and we did an orbitotomy with removal of the orbital mass.
Again, this histopathology of this particular case was totally unusual. What we got was this lesion was very cellular with numerous giant cells. As you can see throughout the lesion, there were numerous giant cells with areas of hemorrhages and this osseous metaplasia. So this was a giant cell reparative granuloma, again a very rare lesion in the orbit. This is again reported in OPRS. Very rare, extremely rare orbital neoplasm with only 9 cases which were previously reported. So you have to distinguish this from ABC, aneurysmal bone cyst. There you have the giant cells which are lining the vascular channels. Here they were just distributed throughout the stromal elements. So that is the difference between the two. So you have to differentiate these lesions. Again a very rare lesion. We just presented all the rare lesions from our center.
Is there any questions from any of the speakers other than for the cooperation? Thank you.
The last day, last show, and thanks for being here. So TAS is an acute sterile postoperative inflammation of the anterior segment, and the clinical significance of TAS lies in the diagnostic dilemma, the pathologic sequelae, and the preventive measures. And we will be attempting to highlight on these issues in the following talks. So we have 4 talks here, and I request Dr. Majumdar to take up the issue on etiopathogenesis of TAS. Thank you, Dr. Das. My topic is on etiology of toxic anterior segment syndrome, or TAS in short. First, the definition. It is an acute postoperative inflammatory reaction in which a non-infectious substance enters the
anterior segment of the eye and induces toxic damage to the intraocular tissue. It varies in intensity depending on the type and duration of the toxin. Most of the cases occur after uneventful cataract surgery and more recently after phakic intraocular lens implantation. It was previously called sterile endophthalmitis or postoperative uveitis of unknown cause. A condition previously termed toxic endothelial cell destruction syndrome is now believed to be a variant of TAS. Distinguishing TAS from infectious endophthalmitis is very important. However, this can be difficult. This will be dealt with in more details by Dr. Michael. Now the incidence. There are several studies. In one study, Ochselik et al. Reported an incidence of 0.8% at their institution during an 18-month period. There are different studies regarding etiology. Some studies which found different etiology are Unal et al. Described a cluster of 6 cases of TAS attributed to butylaldehyde residue on instruments. All 6 eyes developed corneal edema and 5 of them ultimately required penetrating keratoplasty. Glaucoma surgery was necessary in 2 cases. Warner et al. Reported a cluster of 8 TAS cases caused by antibiotic steroid ointment. 3 of the 8 cases required keratoplasty. Glaucoma surgery was necessary in 1. Buzzard et al. Reported 2 cases of corneal endothelial decompensation attributable to the use of generic trypan blue. Now let's come to the pathophysiology. The pathological hallmark is toxic anterior segment damage with cellular necrosis and or apoptosis and extracellular damage resulting in the severe acute inflammatory response. Corneal endothelium is often the most damaged structure because of its inability to regenerate. Toxic agents specifically induce the acute breakdown of endothelial junction with loss of barrier function. Remaining viable cells migrate and spread over the damaged areas to maintain the endothelial pump. But if significant damage occurs, the viable cells are not able to compensate the loss and there is permanent corneal edema. Trabecular meso damage can also develop, resulting in decreased drainage, scarring, and peripheral anterior synechia formation, and ultimately rise of intraocular pressure. Now, what are the sources of these toxic agents? First of all, extraocular substances that inadvertently enter the anterior chamber during or after surgery, like topical antiseptic agents like betadine, talc from surgical gloves, and ophthalmic ointments. Next, the products that are introduced into the anterior chamber as a part of the procedure, like anesthetic agents, intraocular medications like antibiotics in the irrigating solution or intracameral antibiotics, preservatives like benzalkonium chloride, inappropriately reconstituted intraocular preparations, mitomycin C, the intraocular lenses themselves, particularly phakic IOLs, contaminated irrigating solutions like balanced salt solution contaminated with bacterial endotoxin or solutions with abnormal pH, osmolarity or ionic composition. Corneal toxicity will be associated with concentration of free radicals present in the agents also. Next, contaminants on the surfaces of the intraocular surgical instruments as a consequence of inadequate or inappropriate instrument cleaning. First of all, inadequately cleaned instruments retaining blood or other tissues, rust, cotton fibers, reuse of disposables, and detergents. This is a case of mild TAS, first day post-op, after uncomplicated phacoimmersive fixation surgery, and look what we have found. A cotton fiber in the pupillary area. Now, like the uncanny smile of the Cheshire cat in Alice in Wonderland, you know, which remains even after the cat disappears. The bacterial endotoxins persist. Even after destruction of gram-negative bacteria after autoclaving, heat-stable lipopolysaccharide endotoxins from bacterial cell walls may remain attached to the instruments, and bacterial endotoxins may also contaminate ultrasound water bath cleaners. There are other culprits also, like oxidized metal deposits and residues that may form on reusable tubing and metal hubs of cannulas when gas sterilization is used, or impurities of autoclave steam, and last but not the least, residual or denatured viscosurgical devices. Thank you. Next speaker is Dr. Sinha.
Giving this opportunity to speak on clinical features and management of toxic anterior segment syndrome. After an uneventful cataract surgery, if you see such a picture and the patient comes with sudden dimness of vision, it is enough to send a shiver down any surgeon's spine. And the first thing which comes to the mind is an infective endophthalmitis. But there are these good optimists who have come with a nice diagnosis, toxic anterior segment syndrome. And as if it is some consolation, it is non-infective, that is caused by toxins. Maybe toxins are less dangerous than infective agents. But fortunately, it is limited to the anterior chamber, and that is, of course, some respite. So toxic anterior segment syndrome is usually acute and treatable. That is, one thing you can tell the patient that your eye may not have to be enucleated. It runs a chronic course, may run a chronic course, but has a potential for permanent reduced vision. It usually presents 24 to 48 hours after an uneventful cataract surgery or any anterior segment surgery. But it can occur 4 to 4 days to 4 weeks after the surgery, especially when the steroids are being tapered off. And DAS has an habit of occurring in clusters. There are no pathognomonic or classical features for DAS. Most of the clinical features are non-specific, and negative features are more important. That is, it is a diagnosis of exclusion. Investigations such as USB scan and lab tests, aqueous tap, culture sensitivity, vitreous biopsy, etc. can be helpful. So as I said, the symptoms are non-specific, most important being the blurring of vision, pain, usually mild to moderate, and redness which can be variable. So congestion is variable. The 3 important signs are corneal edema, which is diffuse, limbus to limbus edema with DM folds. And the anterior chamber reaction happens to be moderate to severe with hypopyon, with a fixed dilated pupil. The intraocular pressure is usually raised. But the most important negative finding which helps in the diagnosis is an absence of posterior segment involvement or vitreous involvement, either clinically or on USB scan. It's also necessary to rule out other differential diagnoses such as lens matter which may be retained in the angle or behind the iris. Decimal detachment and wound involvement should also be ruled out. This is an example of a patient who came on the first post-op day after an uneventful cataract surgery with a best-guarded visual acuity of hand movement, but the PR was accurate, with diffuse corneal edema and a severe AC reaction, and the intraocular pressure was also raised to more than 30 mm of mercury. On the USB scan, the vitreous cavity was clear since it was not visible clinically. So a diagnosis of DAS was made. And this is another patient who came with a best-guarded visual acuity of 6/60 on the second post-op day with gross corneal edema And on careful examination, we found that there is a lens matter fragment which was impacted at 6 o'clock position. The management of TAS is mainly medical, that is conservative with medicines, and most cases usually resolve. But close follow-up is essential to watch out for the development of complications or sequelae. And then these complications or sequelae has to be managed, and most of them require surgery. In mild cases, the patients can be treated as an outdoor procedure by stepping up the topical steroids, strong psychoplegics, and IOP lowering drugs in the initial stage of AIOC, because timolol can be damaging to the cornea. And later on, as the cornea resolves, timolol can be instituted. Almost all cases respond rapidly with no sequelae and good vision. But in moderate to severe cases, it may be mandatory to admit the patient. I personally would like to admit the patient to follow these patients closely in the wards, and then confirm that the vitreous cavity is clear clinically or on USB scan. Once again, topical steroids are given and then tapered after seeing the response. Strong psychoplegics and IOP lowering drugs are also given. Subtenon or post-septal injections of Kenacort usually help in rapidly resolving the condition, and they also reduce the incidence of CME. Rarely, systemic steroids are also needed. NSAIDs can also be helpful as an adjunct, and there is no harm in giving systemic and fortified antibiotic cover. This is an example of a mild TAS who came on the fourth post-op day with the best cut and visual acuity of 6/60. We can see the congestion, the diffuse corneal edema, moderate AC reaction, and a raised IOP was there. The pupil dilated only dilated a little bit. There was good red flow, and on inlet illumination we can see that there are DM folds, but there was no vitreous involvement. 7 days after instituting medical therapy, the cornea cleared, the best corrected visual acuity improved to 6.9, and there was also less AC reaction. 3 weeks later, the TAS almost resolved with a best corrected visual acuity of 6/6. Not all patients will have the same result. Many mild cases may also develop CME. Moderate TAS, this was first post-op day following a cataract surgery with a best corrected visual acuity of finger counting close to face and with diffuse corneal edema. There was severe AC reaction and the IOP was raised to more than 30 mm of mercury. In such cases, we cannot rely on the instruments which measures the intraocular pressure, but at least they would give a good idea, especially the non-contact tonometers. And sometimes you may have to rely on digital tonometry. 5 days post-treatment, the best corrected visual acuity improved to 6/36, with slow clearing of the interchamber reaction and corneal edema. There was further clearing of the corneal edema, but a posterior capsular opacification developed and remained 2 months post-treatment. And the best corrected visual acuity also stabilized at 6/12. So the prognosis depends on the time of presentation and the severity of the case, and it is quite unpredictable, so the patient should be informed to report as early as possible. Mild cases respond favorably with good outcome, and moderate to severe cases may take some weeks to resolve. Follow-up is quite important, especially close follow-up should be maintained a week early or 3 early, 6 early in the initial period, and then on a weekly basis. Most cases respond fast, and the follow-up should be with visual acuity, the cornea, especially to see that the corneal edema is resolving or not, intraocular pressure, and any sign of posterior segment involvement. Moderate to severe cases run a slow course and may take some weeks to resolve. And even after discharge, the patient should be followed up for signs of complications. The important late complications or sequelae are corneal decompensation, refractory glaucoma, and chronic cystoid macular edema. Iris atrophy and mid-dilated pupil are inconsequential, but they may cause some halos, aberrations, and photophobia. The complications are treated as follows. Refractory glaucoma can be treated with drugs initially and trabeculotomy with shunts in the later period. Corneal decompensation requires an endothelial keratoplasty or a full thickness keratoplasty if there is peripheral synechiae or other complications. Cystoid macular edema can be treated with a course of NSAIDs, especially nipafinab and subtenon triamcinolone, or even topical prednisone acetate. posterior capsular opacification is quite common, and the yak capsulotomy can be helpful after 6 months. And this is a patient who came with severe TAS on the second post-op day of a cataract surgery with very poor visual acuity of hand movement, but the PR was accurate and the intraocular pressure was approximately 28 mm of mercury. The USB scan shows that the posterior segment is clear, but in this case, because of the type of hypopyon and aquastep was done, the gram stain was negative and the culture and sensitivity was also negative for fungus and bacteria. 6 weeks after a topical corticosteroids, subtenon steroids and oral Diamox, the visual acuity improved to 6/60. The congestion and AC reaction also reduced, but there was persistent corneal edema. So an endothelial keratoplasty was performed after 3 months, and the best better visual acuity was 6/12. And this is another case in which 2 months after the TAS developed and it was treated, corneal decompensation persisted, and the best better visual acuity also remained at 6/18. IOP was also raised, so the patient was put upon IOP reducing drugs. So the same patient underwent a DCEP, but the visual acuity worsened to 6/36. And in this case, though the graph was quite clear, there was no PCO, there was no AC reaction. We did an OCD and found that there was CME. So there may be a combination of problems and everything has to be looked for. So the patient was put on a course of diclofenac, bedacitate topically, and the subtenon kenapot was also given. And the CME restored after 6 weeks, and the visual also stabilized to 6/12. This is another patient who came on the 7th post-op day, a bit later than the others, with a very poor vision of hand movement, and the PR was accurate. But as we can see here, the anterior chamber is relatively clear, and most of the exudates are behind the PCI. We did a vitreous biopsy which was negative for gram stain, and the culture sensitivity was also negative for bacteria and fungus. So this is a clear-cut case of endophthalmitis, infective endophthalmitis. But to conclude, I would like to say that TAS is a diagnosis of exclusion, and though TAS is a lesser evil, there is every possibility of permanent poor vision, and at the slightest doubt, the patient should be treated as an infective endophthalmitis. It should also not be forgotten that 56 to 70% of patients with infective endophthalmitis are negative on culture sensitivity on vitreous biopsy, even though they may respond to intravitreal antibiotics. So there is only a very thin red line between TAS and infective endophthalmitis, and whenever in doubt, it's better to treat as infective endophthalmitis. Thank you for your kind attention. I would like to invite Dr. Maiti for his next talk.
Dr. Dash, for giving me this opportunity. Well, I will be dealing the differentiating feature, or rather differentiating TAS from endophthalmitis. A common scenario, or rather what we face in the outdoor, that when a post-operative case comes, the operating surgeon thinks that's a TAS, and on the counterpart, the retina person suspects as an endophthalmitis. If this common scenario comes, if this clinical scenario comes on the first post-op day, you operated 8 post-op case, and the first post-op day you see a horrible vision, intense anterior segment reaction, and you have operated 8 cases, out of which almost similar pictures, 8 are very severe. You really wonder if you ever want to practice medicine again. Now, the problem with the TAS and endop is they present exactly the same many a times. It presents with poor vision, hypopyon, fibrin membrane, but the treatment is different for each entity. In fact, TAS improves in time without a special treatment, but diagnosis of endophthalmitis should be made as soon as possible to achieve a good result. Coming to the differentiation points, first the timing of the disease. The TAS is an unusual inflammation. On the day of the surgery usually occurs between 12 to 48 hours following uneventful cataract surgery, mostly cataract surgery I would say. And endophthalmitis generally presents later. So the presentation, the early presentation indicates more in favor of TAS. Coming to the pain, both can cause significant or no pain, but if a patient complains of a deep and intense pain, it is more likely to be an endophthalmitis. Although pain is quite subjective symptom, it is often highly variable, but most of the studies suggest that there is association of pain with endophthalmitis. As one of the studies has been quoted, that 75% of the infectious cases presented with pain. Coming to visual loss, in endophthalmitis, a very common presenting feature is a marked visual loss. It has been shown by the landmark study, that is the EVS study, that 94% of the patient presented with visual loss. And in TAS, the marked blurred vision is not that common as endophthalmitis. Next feature is the conjunctival and the lead reaction. In a TAS, the lead swelling is uncommon, whereas in endophthalmitis, conjunctival hyperemia and the lead edema is quite common. In this picture, we can see the wound infection, wound infiltration too. Then comes the corneal edema. This is a very important differentiating feature. The corneal edema in TAS is limbus to limbus. It is a 360-degree corneal edema, whereas in endophthalmitis, the corneal edema is mostly localized. An important feature which we should look for is the wound. If there is wound infiltration, then it is unlikely to be TAS, and we should treat in the line of endophthalmitis. Coming to the iris findings, in TAS, there is a fixed dilated pupil, and later on there will be a diffuse iris atrophy, which is an uncommon feature for endophthalmitis. Coming to the intraocular pressure, in TAS there is a profound impact on the trabecular meshwork. Generally there is a high intraocular pressure, whereas in endophthalmitis, the trabecular meshwork is one of the least sensitive structures, and it is not, we don't see a high IOP in endophthalmitis. We might see, but more common with TAS. So extremely high intraocular pressure early in the postoperative period points the diagnosis of TAS. Then comes the therapeutic response. In TAS, the therapeutic response to topical steroid is a definitive test. The steroids can suppress inflammation in endophthalmitis too, but this is for a short time. The patient's condition is worsening despite the steroid treatment, then we should think about the endophthalmitis. In fact, if the vitreous cells appear or increase over time, one must strongly suspect infection, and the vitreous stamp and antibiotic injection, intravitreal antibiotic injection should be given. This is an example of how the therapeutic response differentiates a TAS from endophthalmitis. We see the pre-op picture, intense anterior segment inflammation with a fibrin membrane, and after 4 days with the steroid treatment, we can see it has almost cleared. As we were mentioning that the posterior segment involvement, it is much more in endophthalmitis. What we see in ultrasonography is a dense opacities and the membranous debris in endophthalmitis, whereas in TAS there is absence of vitreous opacities. If it is present, it is very mild, and it is said to be that the anterior segment inflammation seeping to the posterior segment. TAS, as Dr. Prashant had mentioned, tends to occur in clusters, And endophthalmitis can occur individually. In fact, endophthalmitis also can present in clusters, but TAS is more commonly presented in clusters, and if a cluster appears and one of them, if it is suspicious to be endop, then it is better to consider all of them with a clinical suspicion of endophthalmitis rather than TAS. And TAS is always culture and Gram-Stein negative, whereas endophthalmitis, the culture might be positive. In few cases, as it might be negative, but mostly it is positive. Now, to sum up the differentiation between the TAS and endop, the onset of symptom is a very important feature. TAS is always very rapid onset, that is 12 to 24 hours or 12 to 48 hours, as most of the literature suggests. But endophthalmitis is generally a bit later. Pain usually severe with endophthalmitis. Lid swelling is more with the endophthalmitis. Corneal edema is typically limbus to limbus in TAS, where it is localized in endophthalmitis. Pupil is unreactive and dilated in TAS. Intraocular pressure is raised in TAS. Vitreous inflammation is more common with endophthalmitis rather than TAS. And response to steroid, I think the most important, the therapeutic response to steroid is dramatic in TAS, where it is equivocal in endophthalmitis. We have seen the theoretical differences and the clinical features, how to differentiate TAS from endophthalmitis. But what is important, a sincere workup is needed. A patient who presented with TAS should be assessed carefully. The vitreous should be examined carefully to rule out vitritis. In fact, if there is a huge corneal edema or an intense anterior segment inflammation, ultrasonography should be performed. But in spite all of this, still there will be cases where exact etiology is unclear. Then, if that scenario comes, it is better to perform the protocol or follow the protocol for the infectious endophthalmitis and treat the case as endophthalmitis by taking vitreous tap or a biopsy and giving intravitreal antibiotics. So to conclude, until a therapeutic response to topical steroid is clearly present for several days or we can say weeks, endophthalmitis should be a consideration. Thank you.
And as Dr. Majumdar has mentioned in his talk, the sources of TAS are in agents meant for extraocular use, which inadvertently gets introduced into the AC. Agents which are actually meant for intraocular use but have components which cause TAS, or due to inadequate instrument cleaning, which causes residues to remain on the instruments. Now, for the first two sources, product alert and withdrawal takes care of recurrence of TAS. But for the third source, it's very important to properly clean the instruments before sterilization, and this is what I'll discuss in this talk. Now, the general principles of instrument cleaning are avoiding drying of instruments after use, removing all debris, final rinsing, which must remove detergents if you are using any, and sterile distilled water must be used for the final cleaning. We should provide adequate time for cleaning, and we should have a separate instrument cleaning area adjacent to the operating room and the sterilization room. If we are working in a multi-specialty facility, there should be a separate cleaning area for ophthalmic instruments. And definitely it's important to have a protocol, staff training and monitoring to prevent TAS. Now this photograph shows debris remaining on instruments after sterilization, and these are the sources of TAS. We may also have cotton fibers sticking to the instruments during intraocular use, or it may get attached to the eye from the grades. So first, we should provide adequate time for instrument cleaning. So that we can rigorously adhere to the protocol, and we should also have adequate number of sets so that there is no shortage of sets, and we are able to provide adequate time. Avoiding drying of instrument is very important. And immediately after use, we should soak the instruments in sterile water, transport to them to the cleaning area as early as possible, and the cleaning should be completed within 2 hours, ideally. Now, if we are using disposable devices, that is very good because they avert tests. But we should remember they are meant for single use and they are not designed for cleaning because they can have small boards which are difficult to clean. They may have surface damage during cleaning with loose fragments which can cause tests, or they may absorb chemicals used for cleaning. Now, if we are using detergents, we have to maintain the appropriate concentration and exposure time. But what is more important is thorough cleaning of the detergent itself from the instruments before sterilization. And the final rinsing should be done with distilled water. And the detergent should not be corrosive like saline and hypochlorite, and it should not contain aldehyde because aldehyde is fixating. It makes the residue stick on the surface of the instruments. Now, cleaning can be of 2 types, either with manual cleaning or ultrasound cleaning. If you are going for manual cleaning, we have to use brushes, soap water and or detergents. And it should be done underwater so that it prevents aerosolization of the debris. And hot water should not be used because it is also fixating, and hinge instruments need to be opened during cleaning. The cleaning solution should not recycle, and ideally for cleaning we have to maintain a 3-bowl technique. The first bowl containing detergent, the next one containing tap water, and the last one for the final rinse, the distilled water. And the brushes should be cleaned, disinfected and dried daily and changed regularly. Now, if we have instruments with lumen, as we always have in ophthalmic armamentarium, we have to flush both the irrigation and aspiration lines, and this flushing should be done 3 times, and sterile distilled water should be used for the final rinse. But again here, effluent water should not recycle. So here we are flushing a Simcoe cannula, which is an instrument with a lumen with a syringe. Now, going to the ultrasonic cleaner, it's useful in removing deposits from hard to reach areas. But if the instruments are already grossly soiled, you have to remove the gross soiling and then keep the instrument in the ultrasonic cleaner. Appropriate detergents and maintaining their concentration and exposure time as recommended by the manufacturer of the instruments is important. Now, inside the ultrasonic cleaner, the instrument should be placed on a mat and not in direct contact with the metal body of the ultrasound cleaner. And the instrument should be completely submerged in the solution. Hinge instruments should be opened and they should not come in contact with each other. Now, it's important to know that if the liquid in the ultrasound cleaner contains a dissolved gas, the effectivity of the ultrasound process in cleaning the equipment is not adequate. So we have to first degas the solution, and then the cleaning cycle starts with the ultrasound cleaner. And this degassing can be done by turning on the ultrasound machine itself or by heating the solution. And only after the degassing is over, which we can make out by the frequency of the sound or the shrillness of the sound in the ultrasonic cleaner, does the cleaning cycle start. Now, corroded instruments should be excluded because they allow the debris to disperse, and after US cleaning, ultrasound cleaning, the surfaces and lumen should be again washed with water. The daily cleaning of the cleaner itself is important with detergents, rinsing and drying with lint-free cloth. And when we are using the cleaner, it is important that we put in the cleaning solution inside the cleaner just immediately prior to use. Now, after we have cleaned either manually or with ultrasound cleaner, we have to dry the instrument. Luminous instruments are dried with forced air, and instruments with the surfaces of the instruments are dried with lint-free cloth. So this is how the instruments are dried, and this is just a picture of lint. So these are these fibers, very small fibers which we call lint. Now, we all use phaco tips, and this is how we should be cleaning phaco tips. Now, the direction of flow of the water when we are either cleaning the irrigation or the aspiration line is along the direction of the natural flow. And it is recommended that we use 60 ml of water both for the irrigation line as well as for the aspiration line. And we should use the same syringes to flush both the channels with air and dry the surface with lint-free cloth. Now, if we are not using disposable drapes and we are using reusable woven drapes, again we have to remember they should be lint-free and they should be adequately laundered between use so that we don't have any residue or detergents left on them. Before sending the cleaned instruments to the sterilization, it is important to visually inspect them so that there is no debris or damage to the instrument. And while using the instrument, the surgeons should inspect the instrument under microscope before using them intraocularly. Now, this is one good recommendation which I have found from AIOC's manual, and it shows the color of the residue on the instrument, the probable causes, and how to remove them. And this is available on the internet. Now, the water supply of the steam sterilizer should be monitored and it should not contain any residue. And we have to avoid butyryldiide because butyryldiide is a known causative agent for TAS. Now, the cleaners themselves should be cleaned, which include the autoclave, the boilers, the ultrasound cleaner, and the water filtration system, because they accumulate deposits like endotoxin, heavy metals, and chemical contaminants. And they should preferably be cleaned by service agents. Now, regarding the instrument, it is important to remember two issues. One is, if we are trying to protect the tips of the instrument, then we should avoid rubber and plastic caps and use silicone caps, because rubber and plastic caps may melt during autoclaving and they may damage the instruments. And if we need to identify the instrument, we should preferably etch the instrument and not use plastic and rubber bands. Administrative measures are important, which include protocol establishment, staff education, record keeping, and surveillance of outbreaks. So, TAS is potentially sight-threatening. Differentiating from endophthalmitis is very important because management is radically different. Residue, both biological and chemical, as well as cleaning agents themselves can cause TAS. And thorough cleaning of instrument before sterilization is as important as sterilization itself. We expect that you give feedback on this IC, and thank you so much for your kind attention. We can take questions for discussion if any. Yes, please.
About the treatments, can we advise to give is an intravitreal triamcinolone or pseudocytinone or what
I
kind of?
request Dr. Maiti to take it up, the question.
When we suspect that this might be a severe case of TAS which is confusing with endophthalmitis, it is better to consider that a case of endophthalmitis and treat according to the endophthalmitis protocol, that is giving an intravitreal antibiotic.
No, the question was whether intravitreal triamcinolone is an option.
Intravitreal triamcinolone, if it is suspicious of endophthalmitis, we generally give intravitreal antibiotic.
I think just giving triamcinolone alone is not recommended because it stays inside the eye, and if you are giving it in combination with an antibiotic, as we use dexamethasone, that is recommended because it stays inside the eye for a long time, and we are not sure. It may be endophthalmitis. If it's endophthalmitis, then probably intravitreal triamcinolone will be detrimental.
What we give generally in a suspicious endophthalmitis cases, vancomycin, ceftazidime, and dexamethasone.
Because that doesn't remain inside the eye for a long time. Triamcinolone remains inside the eye for a very long time. Phaco tips we change, but not the handpiece. Yeah, phaco tips we change, but not the handpiece. Yeah, phaco tips we change. But we definitely don't use new tips in every case. That is not. No, we can reuse them. We can autoclave and reuse them. Yeah, every case you use a phaco tip. It may be a new one. It may be a reused or autoclaved one. but not the one which we have used in the previous case.
So regarding systemic antibiotics, what is preferred?
I personally go for ciprofloxacin because the coverage is not bad and it also goes inside the eye, particularly if the eye is inflamed.
Can we use Dettol or Savlon for instrument cleaning?
We at a center use using Savlon inside the ultrasound cleaner.
Acetone to flush the tubes?
I'm not sure, but for sharp instruments, there are centers which use acetone for the sharp edges.
And the tubing actually, human.
Yeah, but we can use. You should be using detergents which are recommended by the manufacturers of the instruments. That is important. If for a special type of an instrument, the manufacturer recommends a particular detergent, then probably for the maintenance of that instrument, we should be following the recommendation of manufacturer.
And in the slide for the phacotype, you had shown to pull in, pull the plug.
Yeah, it's along the natural direction of flow. So it goes from the machine side to the tip in the irrigation pathway, and from the tip to the side of the machine with the aspiration. They say that that is a better way to clear up the channels.
And for the air also, and for the liquid cleaning.
Air, I don't know, but for the liquid, definitely yes. For the fluid, yeah.
How to make the phaco probe or tubing completely dry after cleaning?
That is with the forced air inside the lumen.
Still,
Actually, they
once
tell to
completely
clean.
dry.
The manufacturers, they tell you to do the cleaning with the distilled water.
Yeah, distilled water. Yeah.
And after that, even if you keep flushing, it's such a long tube.
That won't be dry.
The one problem is, like, if you are using a torsional handpiece, it's actually difficult to fit in the syringe to the end of the aspiration port. Then we have to use a segment of this irrigation tube, which we use for the irrigation solution, and use that segment to fit in the syringe to the irrigation line of the phaco handpiece. It doesn't attach just like that with the torsional handpiece.
Yeah, you have this yellowish rubber.
Yes,
Actually, it is
yes,
made of rubber, not silver.
Yeah.
Hair dryers are very wonderful things. Simple hair dryer. Very good. Hot air.
Lumen of the tubing or the probe?
That you have to flush
That
it
you
out.
have to flush 2 times with
Is there
air.
any special blower or?
No, I don't know. I am not aware of
You
that.
can design a funnel, a small funnel, and put air dry.
Hair dryer you can use for the service.
It's a nice idea.
Hair dryer is wonderful.
And you can use a funnel attached. Just occurred to me with that rubber tubing.
Even after your 10 or 15 applications, so then below there you have some moisture on the bottom. It won't be completely dry.
Yeah, it won't.
Yeah, it won't be
So
completely
you
dead.
can
That's
try
true.
as much.
Do we autoclave fluids? Do we autoclave fluids?
No, fluids are never autoclaved. Viscoelastics are never autoclaved.
Another thing, my personal opinion, once I was used to using the plastic
Yeah, BSS.
paste,
Yes,
BSS
yes.
or the ringer lacquer.
Yeah.
And just somebody suggested to use the glass ones. So I had very mild
Glass
task.
BSS or linear lactate indigenous?
I had a mild task with BSS and not with the ringer, which I was using regularly.
Okay.
And then I went back to ringer.
Okay.
And then
Actually, we personally had a very bad experience with the indigenous ringer lactate solution, and after that we have shifted to this bags, BSS bags.
And then I was using the bags,
Yeah.
and then somebody just said, you just discuss it. You say it's better to use bottle. You can autoclave it also.
No, actually, as a principle in our center, we are using bags, plastic bags, so no question about
And
it.
I had task with my task with the bottle.
Okay.
Went back to the bags.
Okay.
So the simple experience is what works. Is like one of the speakers said, what works for you, keep that.
Yeah, actually, we should not change protocols very routinely.
You recommend phaco probes also with detergent they should be given? Or a plain distilled water?
Yeah, that's an issue. Now, there are people who don't use any detergents. and that is also a very recommended practice. Like if you ask me what we do in our center, being involved with the OR monitoring process of our center, we are using detergents only in the ultrasound cleaner. Whatever we are cleaning in the ultrasound, we are using detergents. Otherwise, flushing lumens, other instruments, we are not. We are just using tap water and sterile water for the final use, the distilled water. Because cleaning those detergents is also a difficult task. And everybody is in a hurry when the OR session gets finished in the evening. And so that is a constant headache for someone who is responsible for the OR monitoring. So you have to simplify the process as much as possible.
Is there any study? They have been using intracameral Vigamox and everything. Why not to put Vigamox or in the fluid and then clean the close the tubing with Vigamox?
I don't know. I haven't heard about it. I haven't heard about it. I haven't heard about it. Here, this is, we have to think about the two aspects differently. One is sterilization, that is infection, and one is cleaning, that is to prevent a sterile inflammation. Vigamox is to prevent infection, not for test. So we have to keep these things, consider these things separately.
Sir, supposing we have got a cluster of tasks in one single day. So, how do you go about it? How do you identify
the first thing I ask my OR staff is, when did you start cleaning the instruments and how long did you take? That is the first thing I ask my OR the OR personnel who are involved with cleaning the instruments. And that generally gives me the answer. It is always, almost always, a constraint of time during the cleaning process. Somewhere, somehow. Either the detergents or the residue, something remains. And maybe 3 months, 6 months, once in 3 months, 6 months, we have a cluster of tasks. Then we again discuss with them, again tell them the importance of cleaning the instrument, and then again for another 6 months, 3 months, 6 months, nothing happens. And they get lax. And this is what happens with us. I think it happens with everybody else.
No, sir, but even the intracameral fluids may cause test.
Anything can cause test.
So then we should
Anything
change
can
everything. Do you suggest we should change everything?
No, if we have, we are using a new batch of something, whatever, new batch of agents. So probably we should first think that probably they are responsible. Maybe a new batch of visco, maybe a new batch of fluids. Okay.
So we should change the entire batch of all the intracameral fluids?
Yeah, we should do so. And the companies, they do take them back.
Because we had one bad experience of tests spread over almost a couple of months. We could not identify what was the exact cause. We changed the instruments, we changed the bloom, we changed the RL. Ultimately, at the end, we came to know that it was because of visco. The moment we stopped using that particular visco, the entire episode stopped.
Yeah, because almost I think 80% of us are using indigenous viscoelastic. And if you look very carefully under the microscope, we see these particles in the viscoelastic. That means they are not properly filtered. The indigenous ones, the low-cost ones. And that is also a source of test. If you are using a higher grade viscoelastic, the costlier ones, you will not find any particles under the microscope. But the indigenous ones do contain these particles because they are not properly filtered.
You are recommending separate paper tips for each case?
Yes. May not be new one,
Okay,
maybe a reused one,
autoclave
but
one.
definitely autoclave.
There are
But
6 or 7 cases. Do you have separate eye cannula for all cases?
no, we don't.
Then what is the...
No, we don't.
Then what eye cannula is the same for the first patient and the sixth patient?
Ultrasonic tip itself becomes disinfected because of ultrasound. Tip becomes disinfected
Yeah, because of
because of ultrasound.
I didn't get it. The ultrasonic?
Ultrasonic tip itself becomes disinfected.
Sir, disinfection is infection. We are talking about residues.
That's what I'm saying. But he is asking us the same question I'm answering. Tip itself becomes disinfected or whatever, say, sterilized itself by phaco ultrasound.
Sir, disinfection is
Why do
endophthalmitis.
you want to change again and again? He's asking the same question.
Disinfection is sterilization, sir.
So why to change the tip for 2 cases or 3 cases? You wanted to know this
the
question.
same.
We don't change. I don't
So
change.
what we do, we change tips, but we don't change the irrigation aspiration
So on the
cannula.
change, you go
We-
for eye cannulas. They should be changed.
No,
what I think.
we clean them with this alcohol, what we have, and then we wash them, and then we use them.
Most common cause for TAS, what we are asking, is basically viscoelastics.
Yes.
99%
Viscoelastic, dried viscoelastic,
Change of
which
the
is-
batch, change of the fluid.
and dried viscoelastic, which is not properly cleaned from the instruments.
The moment we keep the syringe with the viscoelastics reverse manner, particles also go.
Yeah.
Usually the cause of TAS becomes
Yes.
viscoelastics.
That's why they
Change of a
should
tip is not much of a concern.
No.
This is what I feel.
You should keep the cannula in a water saline bowl. I mean, the visco cannula dipped into a saline bowl rather than on your table sheet. I mean, that's what everyone does, I guess.